Good morning, and very much huge thank you to Evan and Rod for inviting me to come and do this talk with yourself today and joining Calf Month. Even though we're talking about the Achilles, that the two are obviously intricately linked when it comes down to injuries, injury mechanism, and also the group, the population that we see with these disorders as well. So what I'm going to do is take you on a bit of a whistle-stop tour of Achilles problems and the what, when, why, and how of rehabilitating them as well. So first thing first, obviously I've not got any areas of disclosure that I need to make to you. So hopefully that's all clear cut. And in terms of the learning outcomes for what we're covering today, the idea really is to give you a bit of a background about the process, the pathophysiology of tendinopathy. That will help us understand the disease itself. And then what we're going to do is look at risk factors and how they interfere with these particular elements. Alongside reviewing some of the epidemiology, so that the people who actually get these conditions, because that will help us understand all of the interplays between these various elements. And then that will give us a better understanding of how we actually want to go about rehabilitating these patients that we have, because let's face it, some of them are quite tricky, and occasionally some of them are relatively straightforward. So yeah. Now, one of the big things that I like to draw attention to is the frequency that actually tendinopathy in the lower limb will occur. So with the Dutch general population studies, what we can see is gluteal tendinopathy is very, very common in comparison to sort of the other tendinopathies. So we should be seeing a large number with gluteal tendinopathy, and the Achilles sits at around 2 per 100,000 people over the year. So depending on your population size, depends on what you're seeing. The reason tib post is in red is that the tibialis posterior data comes from a separate study that was done on UK women over the age of 40. So the number is actually probably likely to be significantly less than that, but it wasn't captured in the Dutch data. Not really sure why, but it's one of those little bits that sometimes we need to sort of tease into. The big thing about tendinopathy, though, is actually it's got a higher incidence based on that data compared to lower limb OA. So actually, we should be seeing a large number of people with these tendinopathies. And if you're not seeing many people with hip tendinopathy, so gluteal tendinopathy, it's likely that we're maybe misdiagnosing them, and we're actually sort of ending up giving a diagnosis of other muscles and tendons around that area, or even hip osteoarthritis. So just bear that in mind. But we'll stick with the Achilles for the rest of the talk now. Now, when we look at data for different sports, we can see variations in the number of people suffering Achilles tendinopathy. So this data is from the UEFA football research that's been done, and the vast majority of people with an Achilles problem will be a tendinopathy. That's 96% of them. So around 4% will be tears or ruptures. Typical time loss is sort of relatively small, but bearing in mind that this type of project will pick up some of the smaller injuries as well as the more profound ones. So there's a large number that will go on to re-injure, and that's one of the key aspects really that I think we need to tee into, that we'll get around about a third re-injuring, which is something we see in clinical practice as well with relapses, and actually probably put it at a higher level of relapse. But it's whether those people need to seek actual care for that. And one of the aspects that overlays with the calf is about older players being more frequently injured. And that's something I think that we observe and maybe need to consider why that's the case. When we look at rugby, so rugby union in this instance, what we'll see is that certain playing positions, the forwards, tend to get more Achilles tendon problems than actually the backs will. They also have more time loss as well related to calf injuries. You can see that's just below, second one below the Achilles data there as well. So forwards actually get a lot more sort of plantar flexor induced problems than the backs do. And this is something that we're working at understanding at this moment in time. Now, when we look at our normal population that we see in the clinic, what we tend to see is the typical description of the weekend warrior. It's the older, active, athletic person who's often got young children. They're in their early 40s or thereabouts. So they're trying to train at the weekends, can't fit it in the weekend. These are the people that we see having a spike of Achilles tendinopathies. But we also see another population. We see a population that get Achilles tendinopathy who are in their 60s as well. So we see these two different cohorts. The 60s are really probably related to age-related degenerative changes of the tendon and certain genetic changes that we see. So the epigenetics of the cells will alter over that time. And then the 40-year-olds are a more active athletic group, as we said. So just bearing that in mind, and this comes from some UK sort of data that we have showing that the point prevalence in an active UK running population is around 44%. So 44% of all runners in the UK, according to our large epidemiology survey, will have Achilles tendinopathy at any one time point, which is pretty huge. But there's going to be some potential bias with respondents as well there. Now, the other areas just to realise with this are that we're going to see two different zones of tendinopathy when we talk about the Achilles. We see the mid portion, and around 70% of the tendinopathic sort of presentations will be mid portion. We'll get another sort of split then that is the insertion, and it's not the true sort of actual insertion into the bone a bit lower, it's this cam position where you can see the deep retrocalcaneal bursa on the image there, and that bursa will actually sort of often get squidged against the bone, and this is why we see bursal reactions, or we might see changes in the tendon, or we see changes in the bone and we end up with a Haglund deformity. And all of these changes are really insertional tendinopathy. And the rest of the sort of number, the rest of the percentage is then made up by a combination of insertional and mid portion. And if you're lucky enough to work with athletes over a long period of time, or work in an area like I do, where you'll see people over many years, actually this is something that we sort of see borne out as well. But this was from our epidemiology data. Now, the other aspects are this little graph down at the bottom, the little pie chart down here. Now, the blue that I've just pointed to on there, the blue chunk, which makes up about a quarter of that population, had a sudden onset of pain with the sort of trigger for their Achilles problem. So that was basically where they were doing an activity and had immediate pain during the activity. And really, for me, that's possibly a hallmark for collagen tearing. And we should always be searching for this in our clinical assessment of our patients to see if there's the potential for collagen tearing, or whether we're really dealing with a typical sort of low-grade change in the tendon that's occurred over many, many months, and actually the typical insidious tendinopathy. The other difference we need to be aware of with the populations that we see developing tendinopathy are about potential genetic and racial differences. And studies in America looking at black athletes or black army recruits have shown much higher incidence here. And I think this is something that we also see in professional sport in the UK, where we see BAME athletes, so Black, Asian, minority ethnic, seem to have a higher incidence of various tendinopathies. And what we have here is a 4.5 times increased risk of patellar tendon ruptures, a nearly 3 times, so 2.9 times risk for quads tendon ruptures, and a 3.6 times risk for Achilles tendon ruptures in black army personnel in America. And this is large data. This is thousands and thousands of people. So we can be pretty happy that this data is robust. Okay, so there are something that is different, and the likelihood is it's related to collagen 5.1a genes based on what I've looked at previously. So this is one of the genes we know is related to tendinopathy, and ACL ruptures, and a variety of other soft tissue problems as well. Now, when we get down to the Achilles, we've got to consider all of the differential diagnoses that actually may mimic Achilles tendinopathy. I've got a large list up here, and what we've done is we've put the tendon disorders in purple, and the typical ones that we'll see regularly in the clinic will be these ones in red. So looking at stress fractures, I should actually identify that the various inflammatory arthropathies, so gout and some of the other systemic ones, will also be quite common as well. And the most common one, though, from a mechanical perspective, will be an os trigonum, posterior impingement of the ankle. And it's just ensuring that we differentiate between that impingement and the tendinopathy, and look for the typical aggravating and easing factors that go with tendinopathy, as well as examining the cerebral nerve as a common mimicker of Achilles problems as well. easily missed. And I've seen several patients who've had sort of 6 to 10 sessions of shockwave therapy on an Achilles problem, scans and all sorts, when actually it was their cerebral nerve that was their symptom generator. So you really do just have to have a little peek at that. Now, the other aspect then, when we get into the tendon itself, is about all of the factors that may sort of be present there and actually be separate clinical entities in their own right. So we've got our typical mid-portion tendinopathy, but there's emerging data from the Institute of Sport and Exercise Health in London with Bhavesh Kumar and I've forgotten the lady's name now who did the research. It'll come to me in a minute, where they've examined the area that you have your tendinopathy, whether it's the anterior section, the posterior section, medial or lateral section of the tendon. And they've been able to show some relationship to symptoms being worse when you have a posterior region, sort of this area here, posterior region change in the tendon. And I think that makes it much more interesting with what we now know about tendon fascicles and how the Soleus and the gastroc have separate elements within the tendon and how these fascicles can move in relation to one another. We also have read and sort of learned a lot about plantaris tendinopathy over the last sort of 10 to 12 years or so. And that's where we get medial compression of the tendon from the plantaris tendon itself, causing changes in your Achilles. Now, the other sort of more problematic ones that we see as clinical entities are where there may be collagen tears themselves, whether that's a flap tear and you've got a section that's pulled off, normally on the posterior of the tendon, or splits where the tendon is pulled apart. They're particularly challenging clinically to manage in my experience and many of my colleagues' experience in the UK, and certainly in elite sports, that this is a group that we will try and identify. We will try normal rehabilitation, but often it's the group that we find will fail or actually be made substantially worse during it, including imaging changes in the tendon worsening. And that's when we might actually move to something a little bit more invasive, like injections and boots and a variety of other options as well. The other big bits then, just to make sure you don't miss, are paratenon changes, so pure paratenon as opposed to running in conjunction with the mid portion, and obviously the insertional entities that we might see within the 3 different sort of tissue types, so bone changes, bursal changes, and tendon changes as well. Now, the reason I'm pointing out all of these entities is the research doesn't separate them out. It will actually just go, you've got an Achilles problem, here's your treatment. And I think what we see a lot of the time is a washout effect, that some of those entities do very well with certain rehab types and some don't. And so my challenge to you clinically really is to try and split out these different bits. And when we start to design new research projects, we need to actually differentially diagnose these all out. The risk factors for each of those is likely to be different. For example, the paratenon problems are more likely induced with compression externally on the tendon from footwear or socks or things like strapping and taping, and that causes friction as the tendon tries to slide within the sheath as well. So I think actually our management of these also is typically different, and certainly historically it's been, but no research has actually tried to tease out all of these elements and manage them differently. So whilst you'll be sort of told that they all respond the same, they don't. It's just nobody's actually proven that with a research component. Certainly clinically, we don't observe that, and many of you, I'm sure, would see the same as well. The other big debate that's gone on over the last sort of 15 years is about degeneration and inflammation. I trained and was told it was inflammation. I then learned it was probably degeneration, and now we've moved back to inflammation. And the truth is, it's not probably either end of the dichotomy. It's not purely inflammation, it's not purely degeneration. We have this degenerative change that is driven by inflammatory chemicals and potentially some inflammatory cells as well. But these inflammatory chemicals are the key, and we see changes in the cell phenotype, the cell's activity levels and what it's doing within tendinopathy. And some wonderful work from Neil Miller in Glasgow has shown a whole variety of interleukin chemicals, so inflammatory grade chemicals that trigger adaptations that we see in tendinopathy. So this is a tenocyte, and this is a lovely image showing you. I'd encourage you to read his work, but interestingly, Neil's doing a sort of RCT at the moment, using a interleukin 33 blocker that he identified as part of his PhD work. And this is, I think, showing some promise with changing the tendon structure and the tendon symptoms in patients as compared to normal sort of placebo components. So looks possible, but has got a large expense if we're going to go down the drug route. But equally, these chemicals are all part of it, and we can probably influence these chemical reactions via loading. And we've got a whole variety of models on tendinopathy that have tried to identify what the process is. And I'm showing you a smattering of them here. Most of you will be fully sort of aware of the Cook and Purdon model. That's probably the most used clinically. But I think what we can do is we can amalgamate all those models into one, and we can say that actually we all talk about the cell getting injured and something happens to the cell. It changes its activity levels, its shape as part of that as well. And we see this in Steph Dakin's wonderful graphic here. And what happens then is that cell excretes various chemicals, doesn't produce the collagen structure it should, and these are the chemicals trigger other cell adaptations and further structural change. And this is the process of tendinopathy. And essentially we can be left with a fibrosed area where the cell is overly primed. This is the hyperactive cell I often talk about that gets sort of switched on too easily, and it needs to be calmed down. Or we can get resolution of the inflammation or resolution of the condition. And I think this is useful to think about, that sometimes the cells are hyperactive. The person responds excessively for a given amount of exercise, and we need to calm them down. And our treatments need to understand this process. They need to calm that cell down, stop it producing all of these chemicals. And the best way that we understand of calming that cell down at the moment is via load. So when we see tendinopathy, we see structural changes. We have lovely healthy tendon in the top up here, and the tendon can become enlarged and thickened. We'll get these darker areas, we'll have lighter areas, say hypo and hypoechoic regions. For those of you that use the ultrasound, you'll know this already. But it's this change in the tendinopathic tissue in the bottom two images compared to the top two that is part of this process. And that's the bit we managed to observe. And those dark areas are made up of small fibrils here. So this is the rat tendon that has been chopped, and it's like looking at a pack of spaghetti. So you look at the end, all the fibers should be the same size. And that's what you see in the left-hand healthy control group. And in the right, what you observe is small fibers that are much smaller diameter than they should be, rather than these larger ones over here. And this is the process that is triggered with tendinopathy. These areas are structurally weaker. They're not able to tolerate loads, and we can debate that, and I can show you loads of evidence that substantiates a bigger tendon is not structurally stronger, because you've got these areas in there, more water content, you've broken down the cross bonds between these fibers that you'd normally have, and the tendon becomes structurally less resilient and is more likely to snap. There are some people that may respond with healthy tissue, and that's a different entity that we see as well. So they're the changes we observe with tendinopathy, and the most important bit for you to take home from this particular section is this is triggered with either overuse or underuse. The various animal models have recreated this with stimulating rats with downhill treadmill running, or with making the rat rest by sticking their foot in a cast or severing the muscle. And the tendons degenerate, and this is exactly what we observe. And so by helping our patients understand this, we can help them to balance it out. So all of this structural change, all of these cellular responses and things can be summarized in this one slide, really. We get alterations in the cell populations, the collagen becomes disorganized and less strong, for want of a better term, and the ground substance alters. We get changes in the various chemicals in the ground substance, particularly the sort of lubricant chemicals, proteoglycans and GAGs, and they draw in fluid, and the fluid is essentially edema, which then stretches the tissue and causes further problems as well. And we see these neovascularizations that we've spent many, many hours trying to chase the blood supply and ablate it in some way, shape or form, with not a huge improvement in our clinical care over the last 20, 30 years. So what we, I think, need to do is go, well, we know the cell's the trigger. Why aren't we trying to target the cell if we can? And that's one of the things we'd look at. Now, this video will play. I'm just going to have to drop out of this screen and you'll capture it. So what we'll see in this particular image is this calcaneum will migrate into the Achilles tendon here when the person does passive dorsiflexion. And I thank Peter Gettins for producing this video a number of years back. And just here is the bursa. You'll be able to see it move. So hopefully this will play nicely for you now, and it'll open up. And then we'll go back to the slide. So just in this area, we can see the foot's being passively dorsiflexed whilst the person lies prone. And what we're getting is the compressive element that we know about with insertional tendinopathies. That's why you have a bursa there. It's why we ultimately see bone changes, because in some people, the bone will exostosis, it will grow. In other people, what we might observe is the tendon degrades, and that's because of the compression, and the degradation will link with calcified areas within the tendon. Again, we lay down bone because of compressive loads. So we can be comfortable that compression is part of these insertional tendinopathies. Now, I try and summarize all of that cellular stuff and all of those pathways that we had about the process of tendinopathy into a simple sort of thought process of homeostasis, as we all know and understand. And really what we're talking about is wear and repair. We're trying to get a balanced process, and all of our risk factors that we can identify within the literature, either from an expert consensus I did previously, or actually when you go to the primary research itself and look at that, you'll observe that they can all actually be influencing the wear on the tissue, or they influence the body's ability to repair. And I think this is particularly important and crucial to understand. And then we can give our patients a way of trying to balance this out and lift the level of robustness of the tissue to make this scale sit higher up instead. And training load in our active group is the biggest element. And in our inactive sort of elder population, we're probably talking about things like tendon structure and degradation, increased adiposity and diabetes and other systemic factors that will influence it. So we need to flip what we're maybe targeting. But one of the simplest elements we can actually look at is thinking about, well, training load, previous injury, I can't do much to change, but I can look at what's happened as a consequence, and certainly muscle strength. And our bias sits, I think, with muscle strength at the moment as probably being one of the key elements that we can adapt and alter. And our current thought process is by making the muscle stronger and more neuromuscularly functioning better, robust, I was going to use, but it's the wrong term. So improving the neuromuscular function of the muscle, we can actually help the muscle shield and shock absorb for the tendon. And this is the process that we think is important at this minute in time. Now, many of these previous risk factors that have been identified in the literature and included in my epidemiology work may link to one element. We can talk about them as influencing the tendon, but no study really goes into understanding why these factors are actual risk factors. And it's my sort of thought at the moment, and it's only a thought, so we need to test these theories, and we're underway with trying to do some of these testing at the moment, that actually many of these factors all link to calf strength, calf neuromuscular function, the plantar flexor function, hence my interest in calf injuries as well that spun off from this. And interestingly, we know that previous calf pain, calf injuries is actually linked to developing tendinopathy. So we wonder if they're all about the muscle. And we've focused for years on the tendon when actually we should have been focusing on the muscle. And most of the regimes now will not talk about tendon structural change, they'll talk about improving neuromuscular function. And it seems to all be coming from this same sort of thought process that the muscle can actually help what's happening to the tendon. And there's a whole load of evidence out there showing that neuromuscular changes precede symptoms, okay, in the only study that's ever looked at it, so we're limited with that. But certainly afterwards, we know there's large changes in neuromuscular function, and this isn't them all. This is just a smattering of the changes that occur. And currently, that's where we want to go, really. We know that in some people, even if we match them for sex, for gender, and for weight, so these subjects are about 70 kilos, there's 7 subjects, we know that some subjects have much higher intratendon loads, okay, this red group, when they do a heel rise, and the blue group have a much lower intratendon load when they do a heel rise. Same activity, same tempo, done in exactly the same manner, with large differences in their load despite very similar weights. So why is that? One group, the blue group's getting twice body weight, the red group's getting 4 times body weight, hugely different. And one of the elements, even though it's a small study, may simply be that we're looking at different neuromuscular or biomechanical issues, shank length and foot length. So that's important. Now, we hear lots about structure, and we're told that structure doesn't matter for tendinopathy. That is innately inaccurate. Structural alterations in a person's tendon, if they're athletic, will increase their risk of developing tendinopathy by 7-fold. They are 7 times more likely in the following season to develop an Achilles tendon problem. That tells us structure is really, really important. Now, the problem then comes when we look at systematic reviews that have looked at whether structure changes during rehabilitation. And often they'll look at multiple tendons, and that gets challenging. But what they show is that the structural changes don't correspond to symptom improvement or predict improvement. Now, I'd look at this and say very simply, pain has never corresponded to your structural change. You trap your thumb in a door and you get a black thumbnail. It hurts a lot on day 1. My structure and my pain correspond very, very well. But 3 months later, I've still got a dodgy thumbnail whilst it's growing out, but it doesn't hurt me. My structure's bad, but my symptoms are actually 0. So the problem is we have to look at time points. We have to consider when these imaging might be done in relation to the symptoms, if we ever want to correspond them. And we have to think about how we've controlled it. I can take my runner who's got an Achilles problem, who's got a very sort of dodgy looking tendon on UTC like this. And if he's not run for a week, I can do all the tests I want with him on that day and it won't hurt him. It might hurt him tomorrow, but it won't hurt him on that day. And again, these studies don't control for what the exercise levels have been of the patients or participants or subjects when they came into that particular session. And this is the problem. This is why we've got the watch your step warning notice in the top corner. We have to consider these different entities. Equally, this type of study that's been done has used imaging that really doesn't allow us to go back and look at the exact same part of the tendon we first reviewed, and it doesn't allow us to quantify the changes in the tendon. They're normally using B-mode ultrasound and some of the MRI methods previously. So it's really a case of we've got to use the right method, and we've got to ask the right questions, and we've got to understand it a bit more clearly. Because let's face it, if I've got this tendon, how do I know I'm looking at that same slice on the transverse plane when I look at them in 6 months' time? That's what I really can't do. And how do I grade whether that's better or not? It's very, very subjective. It will depend on the angulation of the probe. We need to use better methods. Okay, things like UTC probably give us a better method for that. So ultrasound tissue characterization, the image that's in the background, and we have work looking at this at the moment. We've got to test it because it's all theory. We don't know the answers, but we need to test it and see. Now, tendon morphology has recently come out as actually being associated. So we've had the studies in the past, and we've got some new work now from Karen Silbernagel's group in the US suggesting that actually these things are related quite well. So the changes in your tendon structure seem to correspond to symptoms and function. And they've now got a couple of studies from one of their PhD students, Patrick Corrigan, that looks really promising. So I think we need to actually reconsider if the evidence was tentatively or over early accepted before we sort of throw the baby out with the bathwater, as the saying is. When I look at the person 8 weeks on or even 6 months on, you can't guarantee you're on the same bit when you're trying to review what the tendon looks like in this transverse plane. And you equally can't quantify how good or bad it is. And this is the problem with that particular element. And also we've got to think about when we're scanning and when we're trying to correspond to symptoms, because it's a problem. If I've had a run last night and I've got a sore tendon, I'll hurt today and my scan may look bad. If I've not run for a week though, my tendon may look the same as it did last week, because of course it takes longer to remodel, but my actual pain is negligible because I've not used it enough to provoke the pain. And the studies that have ever tried to match pain have never actually tried to ensure that they standardize what the person does before they come in. And that's one of the problems with a lot of these studies. And recent data from Karen Silbernagel's group has started to show that there seems to be a link between structure and symptoms, and that seems to correspond with recovery as well now as we move forwards. Of course, I'll share all these slides with Evan and Rod to disseminate from Sophia to yourselves as well, so please don't worry about trying to write down any references or anything. Now, so think about this a little bit more. If we're trying to look at structure, I use the dropping a weight on your toe and ending up getting a black toenail. Essentially, your pain and your structure correspond on day 1 and day 2. It hurts a lot, and I've got a structural change. But that toenail will take maybe 3 to 6 months to grow out. But of course, the pain's gone because all of the inflammation has gone. So my structure is still very bad, but my pain is gone. And this is one of the problems we've got to think about when we consider structure and pain. The two have never corresponded for the vast majority of conditions when we look at it simplistically. But if we consider time points and we ask some deeper questions, we probably have a bit more of a relationship. And we've got some undergoing work on structure and pain at the moment, looking at the site of pain and the site of most structural disorganization. And with one of these bits, the big argument has come from the donut and the hole theory from Jill Cook and Sean Dockin from Australia. And it's something I think we just need to tease into a little bit to understand, because the paper that it was based on was a paper where they identified that we probably don't see changes in the hole in the tendon, the red area in this drawing, okay? And that's down to some papers that have been done on how tendons remodel over time related to some radioactive isotopes, carbon-14. I can bore you to death with the paper and explain it all. It's a lovely paper, well worth reading, from Heimeyer. And what the suggestion is that tendons grow a bit like trees. They grow circumferentially outwards. But there's some problems with that. The paper that the donut and the hole theory is based on actually wasn't a longitudinal paper observing people for a long period of time to see if this hole actually gets better. It was a snapshot. It took people at one point. It's a cross-sectional study essentially, and what we need to answer this question and determine if the hole can recover is a longitudinal study. So let's make sure we apply the same standards, we avoid these slippery slips to ensure that we can actually observe these changes in the future, because otherwise we might throw away something that is actually quite relevant according to Sean McAuliffe's review. And if I've got an elite athlete who's got a dodgy looking tendon, I very much want to see that change. And there's plenty of data showing that they can. Okay, the data has come from sort of various papers here showing tendons remodel with loading, and one of the important ones, I guess, is Lorenzo Maschi and Hakan Alfredson's work showing that this red area on the tendon here recovers. Fair enough, it was a surgical paper, but the surgical paper was removing plantaris, not chopping into the Achilles tendon, and it clearly shows the ability of the tendon's hole to recover and regenerate. And that's been shown by the Australians that have done the same study as well. So I think we need to, like I said, expect the hole to go, but it's not the be all and end all when it comes to tendon management. So we know in healthy people that the tendon itself can remodel. But what we also understand from this data from Bohm is that it needs to be probably large maximum voluntary contractions, 90% of your MVC. Now, how often have we actually utilized that in our rehabilitation for tendons? We've been really terrible at doing that. I'll be quite frank and honest. Most people, until recently, haven't even quantified the plantar flexor strength. And it's only because the data that we've started to show with what we should be targeting that people have now started to pay attention. But the big question I'd ask you is, what will happen when we rehabilitate these? Will this really disorganized tendon actually get bigger? And will this one with the minimal area in actually remodel by shrinking back to normal size? And when we've done some research before we had the UTC scanner and started to use it for this particular technique, we were observing some people with rehab, their tendon enlarges and some shrinks back to a smaller size. And I think this then makes it difficult when papers report the mean change, because we're observing potentially two groups going in diverse directions. One getting larger, and that's probably a good response for them, and one shrinking back to normal size. And that's equally possible for that tendon, and also obviously a good response. So again, we need some more deeper questions when we look at these elements, and that's been missing in the papers that have tried to look at tendon adaptations. We know that tendons that rupture are grossly more degenerative. There's lots of old papers done on large numbers, so approaching 900 tendons showing this clearly. And we know that if you've had a previous rupture, you have an odds ratio, increased risk of 176 times for rupturing your other tendon. And this is based on very large population studies from America. Equally, what we know is that if you've got tendinopathy, you're unlikely to go on to rupture, okay? But when it comes to people who have ruptured, the people who have had previous tendinopathy are overrepresented. They account for 1/3 of all people that have a rupture occur. And in elite sports, we're seeing a little bit of a different presentation, and we'll be doing some work with Rod and Evan on this going forwards to hopefully look at it as a bigger question. So basically, if you've had previous pain, you're unlikely to go on to rupture, and that's what I tell patients. But I actually think there's a group around about maybe 4% of them according to this data, but it's perhaps larger when we look at tendon structure that will go on to rupture. And I actually wonder if it's this particular population, this one on the right here, that are our rupture risk when we've had previous tendinopathy. So we need a large population study to look at that. And what we probably need to consider is monitoring tendon structure. Doing a snapshot in time and going, well, this is terrible, is pointless, because we don't know whether it's getting better or is getting worse. And this is where, again, studies need to serially scan if we're ever going to do any tendon imaging. It needs to use an appropriate technique, and it needs to appropriately scan them for a long period of time. And when it comes to tendons, how I talked about this modeling of repair and wear, we've seen this in a variety of studies that have been able to show this in situ. Magnuson, Lamberg and Kajar have shown this with their lovely studies done on the patella and Achilles, where we can show after loading, the tendon gets synthesis, it gets degradation. The net effect is a reduction in collagen structure for a short period of time, 36 hours or thereabouts. Of course, this has then been interpreted to say we shouldn't load within 24 hours because there's less collagen structure. That is not what this paper tells us. This paper tells us that with 30 kilometers of running, 20 miles, you'll see a transient degradation in the tissue. Okay, it's a huge distance. The same happens for large loads linked to potentially Aussie rules football and similar things like that, where we'll see a transient reduction in structure of the body, but then it improves afterwards. And we just need to be aware of that when we're working out training loads. So where there's been a high load, we then have some reduction to allow the tendon to repair and remodel. Of course, though, if we constantly load this person and constantly load them at excessive amounts, we may then degrade the structure, and that would be one of the expectations. And as you can see, there's a new line that's come on the graph now. We may see that people with genetic or some of those risk factors we had earlier, obesity, diabetes, actually are slower to recover. Or people with a poor diet, people with a lack of protein ingestion in the diet may recover more slowly. And that's probably the group that go on to then get some problems with their tendons. The same sort of process has been identified by Sean and Jill over in Australia, looking at Aussie rules football and horse racers. They've shown transient degradation in the tendon structure for around 2 days, and then it seems to return to normal. And that's linked to water content and an increase of the blue echo types if you use a UTC scanner. We've shown the same thing occurring with rugby union in the UK, and we've got some ongoing work looking at this going forwards in rugby as well. And the reason that happens, the reason the tendon undergoes this transient change in structure is because of the loads that are put on it. And I mentioned load was the biggest factor earlier. Well, every step when you jog is 6 times body weight through your Achilles tendon. There's some people that may have higher loads, but 6 times is what's been calculated from a variety of studies that have been done, and they've all shown the same sort of approximate valuation. If you do a simple calculation to work out how many steps you would take for a given distance, like 10 kilometers, you work out 6 times of somebody's body weight and you then whack it in, you end up with something that looks like this: 1.7 million kilos of force per Achilles tendon for that given distance. And the reason I highlight this to yourselves is when we're rehabilitating our patients, we often have a flare up when they've done something like an additional 1 kilometre of running or even 1 kilometre of walking. Well, that extra kilometre would be 170,000 extra kilos through their tendon. That's a huge amount of extra additional load. And that's why their tendon cells can react and excrete the wrong chemicals, making them sore again and giving them a flare. And that's literally it. We have to understand that what we often have thought about as relatively small amounts of additional exercise can be quite huge. If you want to think about walking will be 4 times body weight per step, and we can do the same calculations for our walkers. And we can use things obviously like modern watches to look at step counts, and that will give us some understanding of what's actually happening there. Okay, so we've not finished yet, but just some of the take-home messages that we've covered so far would be: consider tissue homeostasis. Okay, feel free to take a screenshot if you want. Consider that inflammation is part of tendinopathy, but that doesn't mean we want to use non-steroidals. Michael Kajar and Magnuson are very adamant, as is Neil Miller and Steph Dakin about this, that we shouldn't be using NSAIDs as tendinopathy. It actually blunts the cell's ability to respond, and it's the last thing we need to do. So we just need to calm them down using other methods. Load is probably our central factor that we can do for this. Okay, and by reducing load, we'll get control of pain, which gives us a way in to actually modify things. Please don't throw the baby out with the bathwater about tendon structure. It has a large relevance, but we've probably not asked the depth of questions we should have asked before. And when we're looking at structure, really consider differential diagnoses, particularly in the presence of sudden onset of pain during an activity for a person, or where it started very quickly afterwards. If it's the next morning, we're probably looking at normal tendinopathy. But if I've just done a run and then I'm sore within the next 20 minutes, half an hour, that's more likely to involve collagen structural change that is akin to a tear. And consider with our sedentary patients all of the risk factors that may be at play that are mostly metabolic in nature and linked to tendon recovery and health. Now, when we then come to the muscle and what the muscles do, and this is obviously where my research went, calf strength of below 50 Newton meters is a prospective risk factor identified in army work. We know that when we look at the calf, we want to look at the 2 different muscles, and Soleus makes up the majority of the calf muscular complex when it comes to cross-sectional area. The Soleus itself, when we're running for our Aussie friends here, contributes a large proponent of the propulsive forces, a vertical force of more than 50% of total forces based on numerous studies. That equates to an intramuscular force of approaching 8 times body weight, no matter really what run speed we do for the Soleus, and around 3 times body weight for the gastroc. And so for jogging, these are the primary muscles that are working. The faster we go, that will shift to a proximal strategy and see the hamstrings kick in. But remember, it's our endurance runners that are the ones that are suffering the most Achilles problems. And when we think about that, we can see these 2 muscles working very, very hard. We can see that when we look at the acceleratory ability and the vertical forces, so vertical forces in the bottom here and acceleration here, we can see that Soleus actually makes up the vast majority of it for the run speeds that we have in this particular sort of paper, so up to 5 meters per second. The other muscles don't sort of cut the mustard really. And the important bit is what we can't do, and one of the take homes really from this is we see physios often try and rehabilitate glute max function to compensate for Achilles tendinopathy. The glute max doesn't do enough. Focus on the big fish, Soleus, make sure that you get that better and rehab that, not focusing on glute max. If you've done all of the Soleil and plantar flexor rehab already, then by all means start to add in some other elements. We're not saying it's totally irrelevant, but it's not the most important thing. And I see a lot of failed rehab where physios have basically responded and tried to treat that particular aspect when it's by and large irrelevant for that individual. Sure, you've seen this in Tanya's work as well, but the soleus has the largest physiological cross-sectional area of any lower limb muscle, and it's not anatomical area, it's the physiological area, which encompasses the amount of sarcomeres and the angulation of the fibers, pennation angles. So please be aware of that. That's how it generates these huge forces, and that's important. And when we talk about huge forces, it works at a very high threshold every step. It works at around 84% of your maximum voluntary contraction every step you take when you're jogging. Okay. And in my data, which I'll show you in a minute, healthy people's 84% would be about here. Okay, 117 Newton meters. Our injured population on both legs will be working well below that, just suggesting quite strongly that they're going to have to compensate. And tendons compensate for weakness in muscles by buffering the muscle. And that leads to changes in the compliance of the tendon, and it makes the tendon become more compliant. That is exactly what we see with tendinopathy. It becomes less stiff, and that's part of our problem. Equally, we've got to think about sometimes buy-in. And if we get the calf stronger, we can improve the ability of people to sort of sprint faster, potentially. It's not been done in that way that I've just said. It's been done as an association study. So we do need to intervene and change the strength to see if that works. But we also need to think about the calf complex and therefore the Achilles as being relevant to other non-straight line tasks like cutting maneuvers. I apologise because it's missed the reference off this. This comes from work from Sports Santry over in Dublin. So it's Edna King's work, this is, showing there's a strong relationship between the plant effects of power and your ability to cut at speed. When we look at the anatomy of the Achilles, we can see it's quite complex. We've got fibers that link to the soleus, fibers that link to lateral gastroc and medial gastroc. And essentially, we've started to go, well, where do we see tendinopathy? Is it in the soleal fibers or isn't it? And our current understanding is it may well be in the soleal fibers. It's this deep section is the most common area we see tendinopathy, or the medial section. And that's equally part of the soleus as it rotates and inserts down into the ventral aspect of the Achilles tendon. And that's what actually interested me in UTC scans initially, was that we might be able to look at this and sort of identify those bits. Now, one of the important bits is to understand how strong these muscles are. Okay, it has it on here. We should be looking at twice body weight as our particular aspect. Okay. We need to think about these risk factors being linked to the neuromuscular elements, not just about the tendon structure. And this study we did a little while ago basically identified that soleus was most at fault. We did knee flexed positions and knee extended positions where both gastroc and soleus work versus knee flexion. And what we seemed to show was that the deficits between healthy people in green and the injured cohorts, bad leg, being the symptomatic leg, was blue, and the non-symptomatic leg was red. We identified the healthy people are stronger no matter what test speed we use in this isokinetic testing, 90 degrees per second, 225, and then eccentric at 90. And we did that between the two test positions. What you need to notice from this is you can't use their non-injured leg as a target. You can see there is very little difference at these patients, no matter what test we do. Okay, and that means we need healthy data for our target for recovery. We use age, sex, and activity matched controls for this study. It was a relatively large study, so we had 38 controls, 39 injured participants. So it's the largest data set out there when it comes to this, and we did lots of testing, report lots of different elements based on the same data, essentially basically saying, well, no matter how you look at strength, they're weaker. Whether you look at peak torque, whether you look at sort of average torque, whether you look at the endurance, they're all down. And so we know these are problems. Endurance is a bit different. We've got healthy folk here, bad leg, good leg. There's differences on all of those actually throughout it. And even after rehabilitation, we get them stronger, but they're not quite back to the healthy levels. Okay. And what this tells us is after 12 weeks of rehab for these individuals, the rehab needs to be a bit better. we need to do more. We're not rehabilitating the neuromuscular deficits that we can observe. And this is probably why people go on time and time again to get relapses in their tendon complaints. I don't think heel rise is a useful measure to use at this moment in time. Okay, I think that it's not got data to substantiate there's a difference between our people with and without tendinopathy, so be cautious. And if we tease into looking at the traces we might get from an isokinetic dyno for somebody with Achilles tendon problems, we'll see on the top that we'll get these deficits in particular ranges, whereas our healthy control is a lovely smooth line. And when we look at the eccentric data on the right, we'll see these deficits where there's very little force generated. And this occurred on both legs, even though in this individual it was a unilateral problem. And they're an elite Premiership footballer. So in some individuals, doing further neuromuscular testing is much better than just using a standard isometric test. Okay, and we normally see a lovely smooth trace like this, and what you can observe is these oscillations when we look at it. And I'm hoping to finish some work we started with Rod back in lockdown last year, but work took over and I've not managed to send it all through looking at this. But that tremor is a physiological tremor linked to the fast twitch motor fibers not contracting smoothly during an eccentric activity particularly. And we have looked at why this might explain recovery and tried to come up with an explanation based on a paper that we've done here before. But equally, Pete Manieres has identified that when we look at recovery, torque, work and endurance seem to be the only thing that teases out in the literature as what changes during rehab, and it seems to be these changes that are critical. I won't show you the videos, but you can catch up with that when I send them through. But we can see during this activity of heel rise, the person shaking as they do it. And it's that movement that is this muscle tremor. And we think and have published work on this, suggesting that that may put more stress through the tendon and create greater hysteresis within the tendon. And this process of greater stress and greater hysteresis may well be the reaction that then triggers tendinopathy in its own right. And we think rehabilitation should probably target smoothing out these neuromuscular oscillations to actually reduce the stress through the tendon. So we target the muscle because we think the muscle is the key rather than targeting the tendon. And our targeted rehab will involve a variety of work positions to try and rehabilitate the tendon and make it a neuromuscular task rather than a tendon load task. And that will be our particular target here. And we should consider some of the positions as well from Craig Purdon's work, considering that. So neuromuscular seems to be key. Consider, it's all right, I'm aware of time, I'm just going to wrap up. A couple of questions, guys, I'll let you ask them in a second. So we want to quantify strength. We can use that a variety of measures to do so. Consider the pain monitoring as we go through. And rehab doesn't seem to matter what we do. We can do a whole variety. It all comes out in the same format. Isometrics probably not all is cut out to be when we've looked at it, and we shouldn't worry about using it specifically. So don't add in a load of additional things like ice and NSAIDs. Try and avoid those and rubbing the tendons too much. Don't stretch them, and make sure we consider the person when we look at rehab. So basically, they're the big things that we need to think about. And we should look at this progressive rehab all the way through from load monitoring right through to progressive energy storage phases. And they're our big take home. So sorry about the timing. I'll let you guys fire away.